Thank you, everyone, and welcome to the Meet the Authors for the Diabetes, Footcare, and Dark Skin Tones Handbook, which was launched last week. Um, it's published by Diabetes Africa. We are a non-profit organization which serves to improve outcomes for diabetes and related diseases for people based in Africa and the Caribbean, but also people of Black heritage globally. We want to say a big thank you to the Royal College of Podiatry, who supported us in creating this resource. And a huge thank you to Mölnlycke, who gave us the backing and the support and sponsorship to actually build this resource and turn it from an idea, a vision, into something tangible, a reality. I would like to start off by just saying why is foot care important? I guess it's for us, it's obvious why it's important, but maybe because feet are often hidden. Some people might think there's some stigma surrounding feet. It's maybe not spoken about in the same way as other conditions. So we see from the statistics that the 5-year mortality rate for people who have had an amputation or have a diabetes related foot ulcer is really high. About 50% of people die within 5 years, which is horrendous. And as you can see from this infographic, that is actually higher than the combined rate associated with cancer. That is an awful, awful rate. The data isn't so detailed about what the rate is in people of Black heritage or of dark skin tone, but we know anecdotally that it's worse and that there is data, small amounts of data to show that the outcomes are worse. We know of about 500 million people globally who are living with diabetes. In the course of 1 year, about 18% of them will develop a foot ulcer. So if you think about that number of people, the volume of people, and the mortality and morbidity associated with it, it's just a terrible picture. And we thought, okay, right, if we're going to do something, what are the areas that people would most want support? So we ran a poll earlier in the year, and one of the top aspects was identifying skin color changes. And that, I think, speaks to a lot of what we've been hearing anecdotally about skin tone being a major factor in barriers to providing care. But interestingly, we wanted to, check that it's not just us that we had this feeling. Thankfully, one of our co-authors, who I'll introduce more formally shortly, did an event with us 2 years ago on diabetes-related foot complications and why it's important. And although this infographic says 34,000 views, I can proudly say the last time I checked is at 40,000 views, where people are really showing prolonged engagement with the topic. This is an area that people shared that they wanted more information. As we see, the results of the feedback from the event were good. And then we're having comments such as this under the video. This was very good. I wish more health professionals in the Caribbean, especially, would watch these videos. It would make a world of a difference to patients there. Too many people with diabetes are losing their limbs. So we know this means a lot to people. Now on to the people that you've actually come to see, the co-authors and reviewers who are involved in this handbook. Hopefully joining us shortly, as he's traveling to deliver training in India, is Prof. Zulfia Bass, who's an endocrinologist. He's based in Tanzania, but he's the president of DFOOT International. We have myself, Executive Director of Diabetes Africa, the fabulous Luxmi Dumahoon, who's here with us today, a nurse consultant tissue viability from London. We have Chris Manu, who you saw the video with just before, who's a consultant diabetologist, who's co-lead for Diabetes Foot Service in King's College Hospital in London. The wondrous Dr. Joan St. John, who's a physician who's working in primary care with a specialty in diabetes, is a Diabetes UK clinical champion, but is also the co-author of a book you may or may not have heard of called the Carbs and Cows World Foods book, which is a fantastic resource. Maybe one of the team can send a link in the chat in case you're interested. We not joining us today is Jess Schumann, who's a person living with diabetes, who's a huge advocate for progress and making a difference, and he contributed insights to the handbook. Moving on to our reviewer. So that reviewers might be underselling the amount of value and input they gave to the handbook. The handbook is really a better resource for their presence. So it was Laura Lovell, who's a physician based in Barbados with a special interest in diabetes and works with the Barbados Diabetes Foundation. Fabulous Jane Robbie, who is a senior lecturer in diabetes and vascular disease at Birmingham City University, and Debbie Sharman, who's not able to make it today, a consultant podiatrist in diabetes in Dorset. But Jane and Robbie are at the forefront of their profession. They're involved in the Legs Matter campaign. They're involved in so many things, pushing forward advances in foot care and wound care and leg care. So I am honoured to be part of this group speaking about the handbook. And once again, thank you so much for your contributions. Before I move on to the discussion where we speak about different aspects, I'd love to bring in Ali Headley, who's joined us from Mölnlycke. Ali is the UK Medical and Professional Affairs Manager. Ali, would you like to say a few words about why you took the leap? And I guess it was a leap to support us to develop this handbook, and I guess why education is important for Mölnlycke.
Thank you very much. Thank you, Bernadette. On behalf of Mölnlycke, we really would like to say a big thank you to all of those involved in bringing to life this really essential handbook for healthcare professionals. And from a Mölnlycke perspective, it was a no-brainer. You know, we could see in that discussion, those early discussions with you, Bernadette, just how valuable, this was going to be. And I think for all of those who have contributed, your time and expertise, has really produced a fantastic piece of work that, resonates so much globally. And, we're very proud to have played just a very tiny part in bringing this to life. And as a company, we will be ensuring that we raise awareness of the handbook at every opportunity. So thank you very much.
Wonderful. Thank you so much, Ali. Now, moving on to the first aspect we'd like to discuss. Lakshmi, you're currently on mute. If you would be able to walk us through the skin tone tool, how you use it, why it's valuable, and just your experiences, just about a few minutes on that would be great.
Absolutely. Thank you so much, Bernadette. And thank you also for, bringing the skin tone assessment to life, because as you know, this is a really important aspect to reduce inequity in care, especially for patients in diabetes. And me being a practitioner in London, we see a lot of, patients who actually do not know what to look for. And using the skin tone tool is as simple as you use your skin tone tool to know what's your normal skin, and from there you can compare to know what's the abnormal. So what we've been doing alongside educating our clinicians, our healthcare professional, nurses, practice nurses, and carers themselves, we are also educating patients and their loved ones, because very often these people may not have anybody to help them check their feet, especially when they got diabetic related issues or neuropathy, for example, and they don't even know when to seek help. So using a simple tool that can show them, see, for example, as you can see on the skin tone, we make it very colorful, and patients are able to relate to their skin tone. If somebody's skin tone is a 5A, that's their normal skin tone, and their left foot is starting to be 6A, they know something is wrong. And this is so visual that it's really prompt them to get the help they need. And by doing that, we are helping people take their feet seriously, because as you rightly say in the first part, it's like it's everybody's business. And I'm so glad to have co-authors like coming from all over the world in here, but the problem is global. It's not just here in UK. So the more we share it out, the better, because the diabetic foot ulcer problem is global. So simple things like getting our patients themselves to take ownership about early identification of skin damage on their foot can help them prevent an ulcer. And this is where we're trying to get that tool out and about as much as we can.
Wonderful, thanks, Lakshmi. To the other co-authors and reviewers, how have you used the skin tone tool? Where have you found value in it? And if you haven't used the skin tone tool, what is your advice for others regarding how they could move forward? I'm going to coach I come to first. Jane, would you like to go first?
You were going to say that. I think for me, and again, sort of mirroring what Luxmi has said, for my patients, for the people that I see in practice every day, we talk a good story about what people should recognise. And historically, we've always talked about infection and inflammation being red hot swollen. And I think this tool really highlights, for some people, red is not a useful indicator. It doesn't mean anything to them because we don't see redness. We might see paleness. We might see darker skin tone. We might see a discoloration of a bluey tinge into the skin. So I think from my point of view, it's been a re-education for me in terms of the advice that I give, and making my advice particularly person-centered, so that I look at the person that I'm actually talking to, and I think, what's going to be the most useful way of describing this for them, and then giving them that opportunity to reflect it in their own skin tone. So, I often find that I'll say, if your skin tone changes, or if it's not normal for your skin tone, or if it doesn't look like it looked yesterday, it might be a bit darker, it might be a bit lighter, it might have a different kind of tinge to it. And again, I think that's been really useful. And a piece of work that I've been involved in called Act Now, which some of you may be familiar with, we actually reflected that in our Act Now tool, so that we didn't just use one skin tone. We do try to replicate how the Act Now tool manifests in different skin tones. So again, I think it's been really useful in educating clinicians in their practice, and helping patients to recognise when they have a problem.
Thank you, Jane. And some of the feedback I've also received is that I guess the people didn't know there was a way to quantify or categorize skin tone at all, and they were doing it quite anecdotally. So that's been a fantastic learn, actually. That just even the skin tone tool as a tool was a learn. You touched upon it, Jane, but I'm going to come to Chris Manu, please, to talk about the next point, which is don't rely on redness. And I wondered if you could comment on that, please, Chris.
Yeah, I think we've just already touched on that. But yes, when we are all going through medical school or wherever medical training, professional trainer we go, we all been learned to associate redness with danger. And even with let's say junior doctors that I come across quite a lot, when they are presenting a patient, they always look for that redness. And like we just said already, that sometimes the language could be wrong. And I think that's why that is key. And even in some of the guidelines that are written, again, there's the repeated reference to redness meaning danger. And I think as this handbook tries to maybe highlight it much more, is being aware that that redness will not always be there. So I think it brings it out quite clearly, and many thanks to your team and Mölnlycke for helping to perhaps raise the awareness about this much more. So yeah, I think it goes without saying that redness will be missing in people with such skin tone. But one of the way I think around it as well is I'll probably echo to, yes, people knowing their skin tone, but also again comparing with the contralateral side, if the person does have a contralateral foot, about how it compares to the other side of the foot.
Absolutely. Thank you, Chris, for that. And I believe the handbook has made a step forward in really putting to the forefront that you shouldn't rely on redness. So that's brilliant. Laura, can I please bring you in, because we had a comment from someone that said, "Oh, if a person's working in an area where dark skin tone is the majority, then surely they should know this already." But as you saw, we had a comment from someone based in Barbados saying that they wish more healthcare professionals were aware of it. So, Laura, I wondered if you could comment on that particular aspect.
So I do agree that is a problem, whereby persons, although the majority patient load that we would see are darker skin tones, we still learn from the same textbooks. So there are many Eurocentric textbooks, and you're taught still look for red, hot, swollen. So I think it's still re-educating persons who may be still practicing by rote rather than practicing what is culture specific and understanding what the patient in front of them actually has. And I agree with everything that Chris said in terms of looking for contralateral changes, looking for changes unique to that person, because then they're best able to understand when changes are happening with them. So that's something that we're trying to teach the younger doctors now coming, to get that experience.
And it's a great point you make, Laura, about no matter where you're based in the world, actually a lot of the learning resources are based on light skin. So even if you're seeing every day, what are the learning resources? And I'm wondering if I could come to you, Joan, because you're not a foot specialist, you work in primary care. So what was your learning, upskilling? What's your experience of, adapting or tailoring your care to dark skin?
So I think one of the things that we've tried to bring out in the handbook is the importance of patient-centered care and listening to the person in front of you and listening to them with a culturally curious ear so that you are able to address the things that are culturally important to them and that they may be doing within their culture, because that may have an impact on their foot, their feet, their foot care, and their general health. So it was my experience from primary care has been that people have not been aware of the differences in people with dark skin, that in terms of the presentation, but also in terms of the cultural practice. And I think what we try to highlight throughout the book is presentation and also the cultural practices as well that are going to be relevant to foot care within people of dark skin. So I think it's going to be hopefully a really helpful tool for people in primary care. I love the objectivity of the skin tone tool, and also it's so important in terms of continuity of care, recording that actual skin tone for the next person who sees that person living with diabetes, because it may not be the same person in primary care who's going to see that person.
That's a great point, John. The continuity of care aspect is so important, and it somewhat removes an aspect of the subjectivity, which is brilliant. I'd like to move on to some of the common myths that I've heard during the conversation. I don't know who would like to take the first one. Feet are just for podiatrists. Any volunteers? Jane, you
Shall
shook
I
your
go?
head.
Shall
Okay,
I?
Jane.
Oh, Jane's going to take it. Well, Jane's the podiatrist, so I'm gonna jump in, Jane,
Yes,
because
do.
I do think that again in primary care, it's our problem. It's our issue. It has to be important to us. It can't be left for some other speciality. And so we absolutely have to address this. This is together with the person living with diabetes, together we have to look after their feet. So yes, I'm not going to leave it all for Jane to deal with. So that would be what I would say to that first comment.
Thank you, Joan. And and I think just to reiterate from a podiatrist perspective, if we start taking ownership of people and people's illnesses and parts of people's bodies, we take away their own ownership, and we take away people's power, and we disenfranchise them from their care. And I think it's really important in this modern era where we're trying to encourage people to look after themselves and to be self-aware and self-reporting, that we don't just say, oh well, it's all down to the podiatrist. And also I think I've been really fortunate throughout my whole career to be able to work in teams with people. And so, I don't manage the foot on my own. I manage it with a team of other specialists and other clinicians, and I manage it across primary and secondary care. So I think, again, when we're used to thinking and talking like that, we have this sort of multi-agency where, it might be the diabetologist who comes to me and says, this person's got a foot problem. Can we do this? Can we offload it? I might go and talk to a plaster technician and talk to them about, different dressings. I might involve carers if somebody needs something doing in between time. I'll be ringing into primary care and getting their sort of aspect and perspective. So I think again, it's about utilising the whole team and involving the person with diabetes at the very centre of that, and making sure that everybody knows that we share that responsibility.
I love that team approach. Yes, yeah. Chris, please.
May I put a slight spin on it, just to be a bit of a devil's advocate, or to put my twist on it? I think we are slightly a bit more privileged in European or developed countries to have the podiatrists. But I think the way not to make a myth, I think probably feet need podiatrists. And there aren't enough podiatrists. And we all know we need cardiologists, we need a neurologist. And so I think it is underestimated, the need for podiatrists, especially in countries where they do not exist as a profession. So yes, I hear it shouldn't be a myth, so to say, that it's just for the podiatrists, but in areas where there isn't enough podiatrists, it needs to be appreciated that it does require a specialist skill. And I know it might be slightly controversial. We try and teach doctors in A&E, and sometimes it's like flogging a dead horse, if I may say so. You can't replace the podiatrist. In a short form, what I would say is that we do need more podiatrists, because it's a specialist field. And no matter how much we teach people to know what podiatrists know, they are the best people. And we have to somehow raise the awareness that we do need more podiatrists to be able to have all those feet around the world. So just to put a slight twist on it, I think feet needs podiatrist.
Yes, I've hashtagged it in the chat. I know we've got legs matter, but maybe we need feet need podiatrists. I don't know which switched on university is going to run that campaign to increase the recruitment, but I love that, and I do agree with the comment about in low resource settings that there's unlikely to be a podiatrist. And so it's a whole team approach. I think it's the fact that in certain countries, I've forgotten the specific countries, but there are no podiatrists. The profession does not exist. And so you rightly said, Chris, it depends on the context. But thank you, Jane. Thank you, Joan. Thank you, everyone who contributed there. Before we move on to the next myth, I'm going to launch a poll, which is basically ask people what aspects of the handbook they found particularly useful. It's just insight for us. Okay, next myth. There is no time for a foot examination in a consultation. I feel, Laura, please, could you start with that one?
I think that in primary care here, that's something that we commonly hear of in primary care doctors, where they either thought it was something only podiatrists do, or something that only occurs in medical school exams. But I do believe that there is time within the foot exam, because if you don't have that baseline assessment, then you don't know when things have gone wrong. And too many times you see persons that were missed having early peripheral vascular disease 10 years ago and only getting it assessed then when something occurs. So I do think that in each patient encounter, when you have that, we need to have that preliminary investigation, that preliminary foot examination.
Yeah, Laura, you was a great point about things being missed over decades actually, and if the habit of checking. But maybe I can ask Joan to supplement, because you're also working in primary care. So when you're hearing there is no time, I guess perhaps we know there's limited time. So with empathy to the situation, how would you combat that?
So first of all, you have to make time, because as part of the annual review, part of the 8/9 key care processes, at least minimum annually, people living with diabetes should be having their feet checked. So that's vitally important. We all know we're, preaching to the converted here. We all know how important it is for people to have their feet checked, at least on an annual basis. So you have to make time. And the other thing is, don't do a half examination. You need to get those feet naked. Get those feet totally naked so you can properly do an examination, because there's no point trying to do it through tights, trying to do it through any other sort of footwear, just asking the question, have you got any problems with your feet, is not the equivalent of a foot examination. So you have to make time, minimum once a year. But of course, if somebody's presenting with a foot issue, it's going to be more than that. You have to make time.
Thank you, Joan. Of our reviewers, co-authors that work in secondary care, do you have anything to add to that, or should we move on?
I just think in terms of what Joan said about, always make sure you check both feet. Often we will get people in and they'll just say they have one foot problem, and actually when we check them they have 2 feet problems. And often asking the patient if they have a problem isn't necessarily always reliable. People with diabetes can often have nerve damage, which means they can't feel things quite as reliably or indeed as much as they used to be able to. And so saying to someone, can you feel something, or is it painful, isn't always an indicator that they haven't got a problem. We should always rely on a full proper physical examination.
Thank you, Jane. Before we go, you've actually led me into the next myth, but before we go into that, just saying that most people found that the visual guide was the part that they found most useful, but in general, there's a good range of aspects of the handbook that people found useful, which is good. And also, thank you, Basola, for your comment in the chat. It's always lovely to have positive feedback about the impact of the handbook. And I'm glad you jumped for joy. That's showing passion and enthusiasm. And we've felt that. I think we're at about 6,800 downloads already in a week. So it's obviously been a popular resource. Right. Next to that, the person living with diabetes is not complaining. You've touched upon it already, Jane. Who would like, Luxmi, do you want to go first? I guess you're seeing people maybe further down in their process, but
absolutely, thank you. And as I agree with Jade, she really hit the nail in the right place here, because very often I know patients, when they reach a healthcare professional after they've had an ulceration, and you will see that but there was no complaint. The patient never complained over their feet. But as Jane rightly said, these people may have neuropathy. They will not feel anything until maybe they see blood in their socks or on their bed sheet. So this is why it's really important about empowering the person themselves for early signs of checks. Give them a mirror. Tell them to check their feet in a mirror every day, because these are the kind of things that they will physically see and not necessarily feel it. So, and do not rely on the person to come to you, because when they come to you, they've already sustained the damage. That's where they know they've got the damage. So it's important that we act early. And also, I think it's a bit, as you say, feet off of podiatrists only. It goes back to that as well, because as nurses, we tend to think, oh, actually, no, we'll leave that for the podiatrist to look after their feet. But if a patient is already reaching their practice nurse, their district nurse, their TVN, any healthcare professional, it only just asks you or take you a few seconds to say, actually, you're a diabetic. Can I just check your feet? This is part of a holistic assessment, and not wait for the person to complain.
And I think I'm pleased to see that the handbook has had a global reach, and I guess this narrative will be different in different contexts. But there are also probably cultural aspects about the dynamic between the person living with diabetes and their healthcare professional, how comfortable they feel to ask for care, ask questions. Are there some biases or stigma? Or perhaps racism the other way, not feeling as comfortable to touch the person living with diabetes, which is complex to unpick and will differ depending on the health context. But I think it's something that's useful to mention. We go into the next part, which is going to be the discussion. Well, I've launched another poll, which is asking about the barriers. What the barriers do you think healthcare professionals or teams are facing when trying to provide best practice foot care? And I guess you could say in the context of a person with dark skin tone, what specifically is different, and what else could be the need? Okay, and while we do that, I'll go to the first discussion point, which is this handbook has obviously been popular, so the dark skin tone aspect has been a need. And Chris's video is doing exceptionally well on YouTube at the moment, so there is a need. But what are the specific challenges in your experience that you've seen, even when you were a junior in your career, about dark skin tone and getting the foot care right? I'd like to go to Chris. Chris, could you go first to answer that question? And please, others, feel free to pitch in.
Well, I'll probably say yes, on the screen here, we might have the converted, but I will probably say until I started doing diabetic foot in around 2010, 2011, there wasn't enough of the exposure during our training, especially although I trained in London, so yes, we thought, okay, I should have come across quite a lot of people with dark skin tones and so on. But I think going through our training, we do not get enough exposure about the differences so much. And now that, yes, I see diabetic foot all the time, then you become a bit much more aware of it. So I think that is the big missing gap. People going through their training without this being made very clear to them. I don't know if I partly answered that, but
you have, and I think that I actually, before I comment, I'd love to hear from others. Jane, Lakshmi, Joan, Laura, your perception of that question about the challenges or experiences in upskilling in people with dark skin tone.
So if I may, Bernadette, so as a TVN, myself obviously started as a newly qualified nurse. All our digital images that we were being shown when we were having wound care sessions as part of university was all on light skin tone. And even at that time, when you Google any sort of conditions for the skin, you will only see that in a light skin tone. So how do we expect our workforce to know what the same condition look into patient with dark skin? So unless really we change the perception, the way we teach others, be more inclusive and making sure that we're showing them different conditions in a variety of skin tone, we can't expect our workforce to know what they're dealing with. And it is a big challenge that if we're all here today, that means we know the difference, and it starts from us today.
Thank you, Lakshmi. And actually, that mirrors what Laura mentioned earlier about even if you're in a country where the majority of the population have dark skin tone, what was the training throughout your medical professional or healthcare professional? What was the resources? And if it was all light skin, then you're actually starting in a way from scratch. It doesn't necessarily matter where you're based. Laura, I hope I've paraphrased what you said earlier as well. And it would be interesting to hear in the chat if people join, if that's also their experience. Because it links to the second discussion I'd like to have is about what advice would you have to healthcare professionals who might be struggling? So we've had people emailing in and commenting and saying that they've been finding it hard. They're so happy that there's this resource because they just didn't know what to look out for. In people who are just starting the journey or starting this awareness, any advice?
Can I jump in there?
Yes.
So just this morning, I was in a hospital clinic and I was talking to one of my colleagues about this handbook, and we were saying, how useful it was and how it was really, really valuable and really well needed on the ground. And I think, and we were discussing how we would use it and how we would, utilize it in training. And and the surgeon I was working with said something that really resonated with me. And he said, but the best thing to do is just to practice. Look at things, get used to looking at wounds, get used to looking at feet in all sorts of situations, in all sorts of skin tones, and just get used to what you're seeing. Because I think that's the other thing, we rely very heavily sometimes on, oh, well, I haven't been trained. But actually, there is a great thing around just go and have a look, go into a clinic, go and shadow somebody. If you don't work with that population and you want to know what it looks like, find someone who works in that population, find someone who runs a clinic. There are enough networks now. We have social media. You can put calls out to people. Does anybody work in this environment? Can I come and have a look? And just network with people out there and start looking, and don't be frightened to look, and don't be frightened to ask. You know, what do you see? I think I'm seeing this. Are you seeing the same thing? It's like when we feel for pulses. You know, some people can feel and they can feel it straight away and it's there. And somebody else, oh, I don't know whether I feel it, but you're a bit embarrassed. You don't want to get it wrong. You think you might, you know, think people will think that you're not capable. And actually, I think, you know, just get used to, you know, going out there, talking, having a look, having an explain, having a, you know, get used to describing things. What does it look like? What, you know, how would you describe that discoloration? How would you explain it? And I think that was the thing this morning for me, was it was, you know, that idea about just, you know, use it and practice it.
Jane, that is golden. I love that. There's a mix of, you know, don't be embarrassed about asking, get out there, be proactive, use the networks to find someone who does see a lot of people with dark skin. Don't just rely on online resources. So I think we've got a lot of golden nuggets there. Anyone else like to add to that?
Well, recently we've had lots of podiatry students. I wouldn't say lots, but some podiatry students who wanted that experience because let's say they're practicing in an area which didn't have many dark skin tones, but then when they're finishing, they're going to be practicing in one that does. They may actually come here and do elective places so that they can get that experience, because what I call red actually is what the handbook will call red now. So then they're like, oh, this is what it looks like, but I never saw it in an actual person before. So I totally agree with Jane. Getting the practice in, your red just looks different after a while, because then you're able to see, okay, this is what this looks like. And it is off the bat, you know exactly what you're looking at. So it only comes with practice and seeing many, many cases. So
I think Laura and Chris, you might have volunteered yourself to have an influx of people who want to have a wider range of examples. So that's wonderful. And I guess what is the so I guess from this discussion, what's the one thing I'm hearing? Use your network where possible to try and get hands-on experience if you work in an area that doesn't have a large number of people with dark skin tones. I'm hearing that. Obviously, look for resources where there's a variety of skin tones shown. What else? So don't be afraid to ask. I think one that wasn't necessarily mentioned would be perhaps to follow up with if you're in primary care, people in secondary care. Because one of the discussions we had in forming the handbook was we didn't have many images from primary care. It was mainly secondary care. So perhaps some more better linkages between primary and secondary care when it comes to putting foot care as a priority. I'm going to close the poll shortly, but it's just asking about what we should do next. Actually, if you haven't answered the poll, if you could answer it now, and I can bring it to the forefront before we move on to the questions that have been coming up in the chat, and also ones submitted when people registered. So let me just do that and share. So number one, they're like an e-learning module on diabetes, foot care, and dark skin tones. We've also said more video content, an expanded visual guide, and also a roadshow. So basically, all of the above is basically what people are asking for. But that's absolutely brilliant. Right. I think we've elephant in the room. It's probably not for this audience, but I've had it in separate conversations about. It's not necessarily focused on dark skin tone, but looking at feet and smell. I don't know who wants to take that. Jane's laughing. I got a smile out of Joan. I don't know who's brave enough to take. Chris hasn't even got his camera on, so I don't know who wants to take this question about people being scared to get more involved in feet because of the fear of smell.
I said about getting naked, getting the feet naked. You get the feet naked, and then you've got to use all of your senses. So you've got to look. You have got to smell, because that may give you some clues. You have got to feel, and you have got to speak. Because the feet don't exist in isolation. They exist in relation to a person living with diabetes. And you talk to that person and you find out from them, are they, as well as all the other things that we've said, look, smell, feel, have they noticed any changes? Is there anything different? Is there something that they want to tell you about their feet? So yeah, absolutely, you use all of your senses to build that picture and to make the diagnosis.
Thank you, Joan. Anyone else like to comment? I'd like to hear your thoughts in the chat as well, because I know we have a range of people joining.
Can I just say,
Apologies, Bernadette. Oh, sorry, I was just going to say, and don't forget to look in between the toes, because that's something I always used to teach trainees. Look between the toes. Don't be frightened.
I think this is exactly what I was going to say. Sometimes smell is not a bad thing, but it's about, it helps you identify the early things that's happening, especially between the toes. You might see a proper good skin on the foot, but unless you open the digit, then you won't know whether there's fungal infection growing there. And this is, the early signs where if you get them right at the right time, good foot care, good hygiene, you can prevent that getting worse, because it can be debilitating for some people, because as a result of that, they will not want to wear, open shoe, open footwear, because they think the smell is going to impact on their body image. So that's why sometimes smell is not a bad thing. It helps you to identify early things.
And I was going to add to that as well, that I echo that. And most of our patients with diabetes, perhaps the long-standing diabetes one, have got very, very poor eyesight. So I think for patients themselves as well, some of them do pick up on a funny smell, so to say, coming from their feet. So in that sense, it's the senses that needs to be harnessed rather than shy away from. And it's the same for clinicians as well. I've seen many patients on the ward that even before the dressings comes down, they got necrosis, gangrene, before it even comes, the dressings are taken down. And it's something that clinicians need to try and welcome rather than to shy away. The smell from gangrene, necrosis, and once you've smelt it, I think it doesn't leave you ever.
Can I just add on top of that? I think, for me, it's around not stigmatizing these things. If we make smell an issue, then it becomes an issue for patients as well, and then they become embarrassed and they don't want to come and see us because my foot smells, or because I've got this or I've got that. And I think then we drive things even more underground. So I think, reducing that stigma. I'm always very poker-faced about things. It's oh no, this isn't the worst what I've seen. No, this isn't the worst. No, it's fine. Don't worry. You've done all the right things. It's feet get a bad rap. If I've been in clinical practice for more years than I care to remember, and if I had £1 for everyone who says to me, "Oh, I hate your job. Oh, I'd hate to be oh, smelly feet," it's really not helpful for the person who's living with this problem. And I think we need to do everything that we can to kind of take the sting out of the tail of it, really. The smell it can be diagnostic sometimes. It can be, we know immediately that this person has a big problem. We know immediately sometimes what bugs they're growing, because you can smell a certain smell. And I think, for people that live with that day in, day out, it must be very distressing. And I think if we make that an issue, we make it, we make it a stigma for them, and they really have enough to deal with.
Thank you, James. Some really powerful points there, and I hear about them. If we make it an issue, it will be an issue, and it will make it worse for people. And I guess maybe some continued discussion with healthcare professionals about, like, Chris, I love your transparency and honesty. You said it stays with you, and I think you previously said that sometimes in the clinic there is a smell, but I think once that is adjusted for, like, people adapt to that, I think it'll be less striking. And I'm sure people working in healthcare, we are treating bodies, and bodies have smells, and if you're working on feet, if you're a dentist, if you're a nurse, I think it's a really good point. Right. We've got a few questions that came in. Oh, a footsie, I love, by the way, that's another hashtag. Thank you, Pradeep, for that suggestion in the chat, which is, if a patient has comorbidity and are unable to check their feet directly, use a smartphone with a selfie stick to take a footsie, which I think is just brilliant. Right. Questions coming in from when people registered. We have, What can we do to address inequity in foot care with diabetes? And that's from Evelyn Evie, as I see you in the audience. Thank you for joining us. But yes, that was the question. I don't know who to go to first. Chris, what can we do to address inequity in foot care with diabetes? And I guess that's relating to dark skin tones.
Yeah, I mean, I think thanks for what you're doing now. I think it's just raising the awareness, and jobs like what you're doing here and now and putting this thing out there. I think it's raising that awareness. It's very often that, yes, someone gets cancer or anything like that, and it's well published on the media and news and so on. But I think with us working in this field, have to raise that awareness of the because our patients will not speak up. Like you said, they've got a neuropathy, they suffer in silence, there's lots of stigma attached to them, and they hide away rather than coming forward, excuse me to say, to highlight that they've got a breast cancer, colon cancer, prostate cancer. As they will say, no one will come to a party and say, ask for sympathy because they got a foot ulcer. So I think it's up to us working in the field to try and raise the awareness so that it gets to the politicians and people high in power. So well done, and thanks for your help in giving us this platform to try and raise the awareness more and more.
Chris, anyone else like to add to that? Joan?
Education. So education of medical students, our healthcare professional colleagues. As Chris said, when we were training, we didn't have resources like this. Education, so people living with diabetes are more aware of what they need to, what the red flags are, what the symptoms are, what the signs are, what the good foot care is to keep the feet healthy is. And then, as Chris has said, then the policymakers to raise the awareness and the importance of foot care. I've had healthcare colleagues who will say, who seem to sort of minimize the importance of foot care, but we need to raise that awareness. So education is what I would say.
Thank you, Joan. If there's no other comments, I think it's a difficult topic to raise, but I think it's worthwhile that there might be, in some cases, bias towards people with dark skin tones, depending on where you live in the world, and that would need to be addressed. I know you said about education. I think there's also that social cultural education, culture humility aspect that we need to discuss. People might see someone whose behaviors or cultures are different from what they know or grew up with. They might find that challenging to address. I know, Luxmi, in some of your previous publications, you have touched upon this point. I don't know if you want to add any comment to that.
I was actually going to type it in. It's about being culturally aware, because there is a difference between equal care and equitable care. So, we cannot give equal care to everybody with all skin tone. But this is why, as Joan rightly said, we educate ourselves, we educate our patients, their relatives, and everybody living around them. This is the only way to bring equitable care closer to home.
Absolutely. Okay, so let me see. Live will be saved with this resource. Thank you so much, Evie. I appreciate that a lot. And we've actually heard comments coming in already about someone from Australia saying that they're going to use the resource with their Aboriginal communities. We've had people from Sub-Saharan Africa saying that, has been mentioned earlier, that although they live and work in an environment where most people have dark skin tones, they didn't have the resources to necessarily support them. This is a question who came in from a healthcare professional. Actually, it's a bit more clinical, but why is it even in controlled diabetes state, they've said, but I guess with good control of blood glucose levels, why is athlete's foot still a problem? It's a bit left of field, but I don't know if anyone wants to take that question. No takers. Oh, Jane.
I'm not sure that it is.
All right. Okay. That's your answer, Olabanji. I don't think it is the case. And Jane, I guess you're. Oh, Chris.
The only thing I'll add to that is, the person might be making a personal statement, but I think sometimes you can have good control diabetes now but the person may have had poor diabetes control before and may have established neuropathy and complications already. So having people with good control diabetes now can still have foot problems, not just athlete's foot, but it's not just people with, excuse me to say, bad diabetes control that end up with foot complications. So you can get foot complications even if you've got good diabetes control, if I turn it that way, so to say.
Thank you, Chris. And that's a good differentiation. I guess maybe if we're to expand it, if someone's had good diabetes, good control of their blood glucose levels over a period of time and don't have complications, then we wouldn't expect to see more athlete's foot or fungal infections. But if someone has had a history of poor control, they might have the other hallmarks of diabetes foot complications, which would still mean that fungal infections were more likely or more severe. So thank you for that explanation. We've got another one. Oh, a great question from a family member or carer of someone living with diabetes. I love this question. So what are the guidance for people going to their salons to get pedicures, manicures, gel polish, etc.? Is it safe to use ultraviolet light, etc.? Any guidance on that would be useful.
Can I kick off? Number one, tell the person who's going to do your pedicure or whatever that you are living with diabetes. And if they don't know what diabetes is, walk out of the shop.
Okay. Thank you. Thank you, Joan. Jane, Lakshmi, Chris, Laura, anyone else in the chat wants to contribute to that question?
I mean, I think I think for people who aren't, who aren't living with diabetes, to say that you can't go and have a beauty therapy treatment is probably quite difficult and quite restrictive. So I think absolutely what Joan has said. Go somewhere reputable, go somewhere that maybe you've read reviews of that have good reviews, that it's a clean environment. Make sure that you tell them you have diabetes. If they don't want to treat you, they will tell you. If they say that they want to treat you because of whatever reason, and I think respect that. That's not a rejection of you. It's them keeping themselves safe and keeping you safe. And I think tell them that you have diabetes, and again, if they don't know what that is or they seem a bit gung-ho, then I would be walking out. I wouldn't be letting them do anything too invasive. So if they're wanting to use instruments, drills, I've had patients who've had these fish pedicures and have had some nasty infections, anything like that that's a little bit sort of quirky, I might want to be kind of avoiding. But a simple nail cut and an application of polish and a little bit of an application of moisturizer it should not be doing most people any harm.
Thank you, Jane. Yes, Chris?
I think another thing that is on our part as clinicians to let patients know, I look forward to perhaps the day when anyone living with diabetes knows what their foot risk is. The same way as people, as you say, with cancer will know their cancer staging. We have to, maybe that's when I'll probably retire. That'll probably be never. But I think anyone with diabetes after a foot screen ought to know what their foot risk is, low, medium, high. So they need to know. And I think if anyone is going to do that, it's important to know what your foot risk is, whether you've got normal sensations and blood flow, or whether you are moderate risk or high risk. And certainly, it's one thing that we ought to be empowering our patients to know what their foot risk is. And I think it will help with them letting whoever is treating them know as well.
And certainly if people have moderate or high risk, they probably shouldn't be indulging in sort of these activities. But if you have a low risk, then,
exactly.
Absolutely simple pedicure would be absolutely fine.
Yeah.
Okay. Perfect. Thank you so much. We had a question in from Maria. In developing countries, are most diabetes-related foot ulcers neuropathic or neuroischemic?
This is an area of contention of mine as well. And I say all diabetic foot ulcers are neuroischemic until proven otherwise. And people who've got more gray hair than I in the foot field, they know I agree. But basically all I say is that you've got a degree of ischemia in the foot. And the answer is true. as soon as you've got some neuropathy, you have got a degree of the change in the vasoconstriction and how the blood flow works in the foot. So anyone who's got diabetes and has got an ulcer has got a degree of ischemia. And we always, traditionally, we've talked about neuroischemic, like, oh, seeing a gangrene foot or a foot, but it will have a degree of ischemia. So I say all wounds are neuroischemic until proven otherwise.
Thank you, Chris. Laura?
I agree. The only thing I would say different in a developing country, although Barbados is not supposed to be developing, it's functionally developing, in that the lack of vascular capacity in terms of having active wound salvage program with the number of vascular surgeons, I think in developing countries is a problem. So therefore, persons may be ischemic, but may not know until late presentation. So therefore, you may have had an ulcer, it may have healed. You may have never had a foot status to see exactly, or a doctor to see what was your ischemic status or not. So therefore, they may be missed at earlier stage. So therefore, they might be underreporting, and you might just be neuropathic and that's it. So I think that that is a change that might be different from somewhere that you have everyone refer to vascular if they're high risk, are deemed high risk, which isn't the case here.
Okay, thank you, Laura. Any other comment? Jane looks me on that before I move on. No. Okay, excellent. Change of pace or subject. I'm going to go to a question that we had from Ivy, which was, what was the most surprising barrier that the project faced? From my perspective, the most surprising barrier that we faced in getting the handbook together was the volume or the lack of volume of photos throughout the pathway for clinicians that are living in a country where dark skin is the majority. I expected to have somewhat of a challenge for, let's just say, United Kingdom or the US, but I thought going to sub-Saharan Africa, etc., that we would have thousands of pictures to select from, and that wasn't necessarily the case. So it actually took a lot of hard work from Luxmi and her colleagues, Jane, Laura, Chris, everyone who was involved in the project. And I know others more widely contributed images, but maybe there's a piece of work on a campaign to increase the volume of images that we have, and that will have an impact on training. We've talked about healthcare professional training, exposure. There's so much that needs to be done. But like I always, we end up putting the worlds to right when we talk about the lack of data, when I'm speaking with Chris about diabetes-related foot outcomes in dark skin. I think also is the images, because it should not be that someone has to fight to find examples or get that exposure. So that was the most surprising barrier that I faced. Any of the other co-authors or reviewers, if you'd like to contribute your perception or your answer to that question, be welcome.
I think I agree what you said, Bernadette, but what I found during the journey as well is we didn't have any early sign of changes in patients living with diabetes before the ulceration. So that for me was kind of an eye-opener, because there was nobody that I contacted was able to share these pictures with us. So again, we cannot demonstrate to people what the change looked like.
Absolutely, Luxmi. So I agree. 2 key points. Early stage. It's not just that tertiary, secondary, or tertiary care, and also dark skin. We've had the comments about data privacy laws often get in the way. I mean, I to an extent I agree, but pictures, other types of pictures are able to be shared. I don't know why the data privacy laws of someone with light skin would be different for someone with dark skin. So, for example, in the US, we're still seeing a baseline of light skin tone. So I think maybe that's an angle that we need to look at. And I know we spoke about that, Chris, about the legal side of images, etc. But it's something that we have to overcome. And then somebody said, okay, where can we share the images? Maybe that's something we should add to our our list of potential projects. I know things already exist, like Mind the Gap. I think someone just shared there is a resource linked with the Royal College of Podiatry about uh, images of in different skin tones. So that's something we can look into, what we can do more. Before I open it up for the last few minutes to the people in the room, let's just take one last question, which was in resourceless settings now. From what I've actually been hearing, it doesn't necessarily matter if the health system has resources. It could be where you are locally based. Someone could be based rurally in a high income country and might face some of the same challenges. So, I mean, what would be the key take home messages for people who are in resource-less settings, as Raisa has said? Laura, could you go first?
I think it's going to come back down to education, because there have been things that we've been able to do even with low resource settings. So education of nursing staff, although yes, it can't take the role of a podiatrist, but still having competent nursing staff to supplement and help with wound care and help with screening. That is one of the tools that we've used in a low resource setting.
Okay, and that is, so essentially you're saying upskilling of, is it healthcare professionals and people living with diabetes, I guess, so that they kept presenting earlier?
Yes, the persons living with diabetes and educating them, I think, is a barrier here, because what works in a UK or American system in terms of education does not work with a Caribbean person. They're not going to come to support meetings. They don't want other persons to know their diagnosis. It is just not culturally done. So I think trying to find culturally appropriate education, which is something I'm actively working on, trying to find culturally appropriate education, because things that work there do not work here.
I hear that, Laura. Thank you. And it's a shame that Prof. Abbas couldn't join us today, because I know he has a wealth of experience exactly on this topic. But thank you so much to the co-authors of this handbook, to the reviewers of the handbook, to Jeff. I know you're not able to join us today, to the people who have joined us this morning, afternoon, or evening, depending where you are in the world. I felt the passion. Like I said, we're coming up to 7,000 downloads of the handbook within a week, which is just incredible. Chris Manu, you might be one of the most famous people in foot care at the moment with your video, which is just getting so many views. I think, like I said, about 40,000 views currently. And I know you're very humble and shy, so you're probably mortified at that thought. A huge thank you to the Royal College of Podiatry for all your support in the handbook, in promoting the handbook. It's just been so wonderful to have your support and insight into it. And a huge thank you also to Mölnlycke for enabling this to happen. Somebody emailed in and said, thank you so much for enabling this handbook to be free. And I think that the fact that we're able to do it and release it at no cost is a huge aspect, especially in areas where the resources are constrained. Before I close up, would anyone like to say any final words? If you are interested in seeing many of our co-authors and reviews in person, and you're willing to come to the UK, or you're based in the UK already, we have an event in November in London, and there will be a dedicated session to diabetes foot care in dark skin tones. Chris Manu, Joan, Lakshmi is going to be there. Debbie Sharman, who can't make it here today, will be there. Please come along, and also please get in contact with your feedback. If you had an aha moment, or someone left you a comment about the handbook, we'd love to hear how you're doing with it, and if there's anything more we can do. But on that note, if anyone would like to say any final words.
Thank you to Bernadette and the wonderful team at Diabetes Africa for bringing us all together to enable us to do this resource. I hope that it's going to be shared even more widely after the session today. So amazing. Thank you to you, and thank you for everybody who's attended as well. Brilliant.
Thank you so much. Lovely. And on that positive note, thank you for all the comments. Thank you for showing up today. I'm just full of thanks and gratitude. And I look forward to catching up with you all soon. Thank you.